I'm Kim Mezera, and I'm going to be your moderator tonight for the latest installment in our Ortho Trauma Hand online series, 3 cases and fireside series. Tonight, our subject is distal humeral fractures. We'd like to thank our chairperson of our hand committee, Dr. Marco Rizzo, for his leadership. Tonight, we have as our sage, Dr. Jesse Jupiter from Boston, to weigh in on some of the tips and tricks of these difficult fractures. We also have Dr. Brent Bamberger from Ohio to share with us some of his pearls of wisdom, and Danielle Sparks from Indiana, who's going to help us with some tips and tricks on rehab protocols and ways to get our best outcomes. All of our potential conflict of interest have been mitigated. The validation statement, just to know that AO North America does not endorse or promote the use of any particular product or service. And so you may see a variety of different products in the talks, and the individual faculty can disclose those for us. We do have a CME credit available for this course. We do have Category 1 credits of 11.25. They can be claimed after the completion of the series, not just our episode tonight, but the whole series, which there is one series left, or one talk left. And after that's finished, then you can claim your CME for the whole series. All your microphones have been muted, cameras have been turned off. We do encourage questions and to be sent through the Q&A box, and I'll moderate that, and the other faculty will as well, and we'll either answer them individually or we'll talk about them as a group. Our agenda tonight is shown here. We're just going to have some principles, and I'll talk about that, and evaluation. Dr. Jupiter will share his experiences, and followed by Dr. Bramberger, and we'll end up with Danielle Sparks talking about art therapy. And there's some room for questions, and we can try to take some in between, but we'll also have some time at the end for that. Our learner objectives, as shown here. And again, this was our series for 2024. We do have one session left, December 12th. Our last session, compression neuropathies, with Dr. Lee Osterman as our sage, and so please put that on your calendars. We also have an exciting webinar on December 4th, distal radius malunion, so please mark that as well. It's free of charge, and it will run from 8 to 9 p.m. Eastern, so well worth your time. We'd also like to highlight a couple upcoming courses that we have we're very excited about. The Hand and Wrist Fracture Management course in Jacksonville in February, a basics course teaching the principles of fracture management. And then we're excited to have our second year of our Fellows and Chief Resident course in Cincinnati in May. This is a great course for the Fellows and Chief Residents. We do have a cadaver component of this, a cadaver lab, but we also talk about business things and looking for a job and what are the different jobs out there. So some practical things as well as some clinical things. So please mark that as well, or share with any other Fellows or Chief Residents that you know. This is being recorded, and so that link will be sent out tomorrow. And OrthoTV online as well, where we can live stream our AO North America hand events and more. So keep that as well. So with that being said, we'll launch into the first talk. Just talking about the principles of fixation. You know, it's kind of the same for many fractures, but we want our anatomic reduction of the articular surface. We want the geometry restored. We want the fixation to be stable enough that we can start early rehab. I mean, if your fixation is tenuous, it's kind of the worst of all worlds, because you can't move the patient and then they get stiff and then they have a poor outcome. So those are basics, but it sounds easy when we're talking about it. But as you'll see, this area, distal humerus, can be challenging to achieve those principles, because it's sometimes hard to see it. It's a little hard to get to. There's a lot of neurovascular structures. There's stuff around there, soft tissue wise, and the joint itself can be a little challenged to visualize. So, and we'll go into that more, of course, as we go through our cases. Just talking about in general our types of fractures, our extraarticular type A's, the type B's, the unicondylars, and the shear type fractures. And then the type C is the one we all think about, I think, when we think of intercondylar, supracondylar, distal humerus fractures, and we'll talk about that as well. And just to kind of dial down on that a little bit, the different types, just to refresh your memories. I think the type A's we kind of probably overlook a little bit just because they seem to be technically easier, but they can be a challenge, and sometimes visualization wise you can get yourself into a little bit of a difficult situation if they go kind of distal. The coronal shears are tricky, and we'll look at some of those cases. And then again, our type C's, we are the ones we focus a lot on because those are the ones that are probably the most technically challenging. So let's just look at some extra-articular fractures, and just think about that. I mean, we don't really need to see the joint in these, so it's not necessarily that we need an approach like an osteotomy of the olecranon, but they can be very oblique, and then we have a lot of soft tissue considerations at this level with the radial nerve and things. So that makes it maybe a little challenging for plating, but they can be done, and the outcome of these is usually very good because the fixation is typically you have big fragments to work with. You can get great fixation, and you can start to move the patient almost immediately. So the outcomes tend to be very good. Patient satisfaction is high. The coronal shears are tricky in part because they are sometimes hard to figure out what you have, what you're really working with. And so the x-rays aren't always enough. I don't typically get CT scans on the extra-articular ones, but the type Bs, these coronal shears, I think that's where the CT scans can be super helpful, because again, x-rays can kind of cover up some things, and you don't always see what you've got. So I think the CT is often indicated, and I pretty much would probably get a CT on all my type Bs. And the 3D reconstructions I think are great. I think Dr. Jupiter is going to talk a little bit more about that as well, but I think they offer a lot of information and perspective for us when we're planning approach. The one thing that's sometimes a little tricky is your exposure and what approach you're going to plan for. And I think that's huge. That's key to not get your back up against a wall when you're in there and you think you can get away because there's one little fragment, but really you need to see almost halfway across the articular surface, and you don't want to limit yourself with your exposure. So preoperative planning is really super important here. Now the intercondylars, obviously, those are the ones that we talk about a lot. And then the question becomes like, what kind of construct should we do? I mean, what's our goal with these very tricky and technically challenging fractures? Back in the 90s, when we started looking a little bit more at this, there's some studies that came out talking about, the plate construct. What's the best biomechanical plate construct? And at that time, there was a double plate at right angles, so we called the 90-90. So, and that's held us well and served us well for many years. So we everybody in that era started kind of doing that. Then Dr. O'Driscoll and his group started questioning a little bit and maybe looking a little deeper at the stability of the distal humerus. And so would parallel plates be better? And so the goal is, as you see here, if you're looking at the distal humerus, what we want is we need that arch restored, right? So we need the medial column, we need the lateral column, but the articular surface is actually an important part of the stability for the whole overall concept. So it's hard to do that with 90-90 plates. So that's that kind of concept and recreating this arch has been, and rebuilding that arch for stability has been the focus of many studies. And it kind of led to this O'Driscoll principle. And sometimes people tongue-in-cheek call these the 8 commandments of distal radius or distal humeral fixation. But basically the idea is that ideally each screw should pass through the plate, and it should try to engage the fragment that's opposite, that's also fixed by a screw through the opposite plate. And each screw should be as long as possible and try to capture and engage as many articular fragments as possible. The screws ideally would lock together by little interdigitation, creating kind of a fixed angle structure that really is very biomechanically stable and strong. And so the concept sounds great. I mean, these are all wonderful principles, but in real life, it can be hard to do this. To achieve this can be very challenging, depending on how many articular fragments you have. But this is what it would be great to look like on the parallel plating, is to basically have your whole arch, recreated. You have your medial column stabilized, your arch, your lateral column, and you can start moving that patient right away. Question also some people ask, is it locking or non-locking? And with the advent of our locking plate technology, which is super helpful, does it make a difference? And Dr. Jupiter had published a paper and looked at this and found, that really no statistically significant difference in clinical outcomes between a locking and a non-locking construct. But interestingly enough, the locking plates were substantially more expensive at the time. This was 2011, so that may have come down a bit, but I think that's a very interesting fact. So looking at those intercondylar fractures, this is just a case example. You can see that we have, our medial column is disturbed, our articular surface has been disrupted, and our lateral column is, not intact as well. So this is, an unstable pattern. And as we're thinking about rebuilding this, it's nice to kind of reconstruct. I mean, I start with, putting together, if there's a large fragment or two large fragments, try to get, key in what you can and do some provisional fixation and then build off of that. And there's two ways of looking at it. Sometimes if your articular surface is so comminuted, it's worth trying to put that together first and then put that back to your columns. But if you have larger pieces, maybe you can build off your columns and do it the opposite way. And I think there's no right or wrong answer with that. I think it's you use what you're given and you take what you can do. But you can look at it either way. Positioning, just to kind of, this is a great position. You want to kind of approach these things because you need the broad exposure from the posterior side. If you don't happen to have this kind of setup, you can still do this with putting the arm over the chest with a bump. So the patient would be supine, maybe airplaned a little bit away from the surgeon, but you could still get this posterior visualization. But if you do have this equipment, it is nice to have this stable, and the arm is more stable than if you put it over the chest, but you can get it done either way. Just to go posterior, you can do a straight posterior midline. Some people curve a little bit, but and then looking at kind of if you just to orient you, the patient's shoulders at the top of the screen, the hands at the bottom of the screen. But often you get there, and like I said, you're thinking, as you're looking at this, you're thinking about the principles, and you're thinking, okay, I know what I need to do, but can it happen? I mean, how can I get all those long screws in there, and how many screws can I put in the articular surface and get them all to kind of articulate with each other? But building it back, just take 5 pieces, make it 4, take 4 pieces, make it 3, etc., and kind of put it back together like a puzzle that way. Stabilize your articular surface. Usually there's going to be an impacted piece near the trochlea, so try to get that piece back out and try to either raft those small, if they're very small articular pieces, maybe use one of the long screws as a rafting thing just to support that. If you can't, and try to get a smaller screw in the piece, and then bring your columns, and get those things put back together, and then you'll be good to go. So again, just kind of looking at those, but that's the look. And so looking at the optimal construct, there's a lot of stuff. I just chose this, but there's a lot of data out there about the biomechanical optimization, and I think the trend currently is to use a pre-contoured plate that are parallel, but that recipe doesn't fit every single fracture pattern. So you do have to be able to flex and bend. And maybe a parallel plate's not going to work. You're going to have to go back to the 90-90. Maybe a pre-contoured plate's not going to fit. You have to be prepared to be able to, contour your own plate that fits. So you have to have a lot of tools in your toolbox and be prepared with this particular fracture pattern for a lot of surprises. So that being said, I'll stop sharing and I'll turn it over to Dr. Jupiter, and he can take it away from here.
Okay, thank you very much. I appreciate the concise introduction. And thank you, AO, for asking me to participate. I realize that it's almost 40 years since I published the first operative treatment of distal humerus fractures from the AO. It was 1985, and I had been a fellow in Basel, Switzerland. Well, I'd like to look at this from point of view of some tips from having had, I think, a fair experience with this. And I hope that look at the learning objectives that we can look at decision making and preoperative planning. It becomes more important as the fracture becomes more complex. And recognize, as Kim mentioned, some of the more complex types of fractures where the articular surface may be partially involved, and then look at some of the considerations when dealing with the older patient, perhaps with underlying osteopenic bone. Having said that, I hope that you can take away that preoperative planning is really important, and the use of not only CT scans, but 3D CT scans are exceptionally important, particularly in that older age patient population. And then realize that certain articular shearing fractures may not be the same and may have, in fact, inherent differences that may present with some surgical challenges. And then once again, the take home being maybe where total elbow arthroplasty fits in. It's not new. And at the Mass General in 1868, Chief of Surgery talked about the problems of the distal humerus, that these injuries are frequently productive of discontent, perhaps so often the cause of litigation. It shouldn't surprise you that litigation has been around for well over 100 years. Well, let's talk about the CT scan, because it's very hard to understand this fracture. And not only with a CT scan, but a 3D CT scan, and then eliminate the radius and ulna. And then you can three-dimensionally look at this much more clearly and much more definitively. Some fractures are really a triplane. They may involve coronal and vertical and transverse fracture patterns. So what's the approach and what's the fixation may be critical in trying to figure out before you get to the OR. This patient had a very nice internal fixation. Here's another example where if you look at the x-ray, it's really hard to tell what you're dealing with. And if you go in looking at this at the initial exposure, there's multiple fragments, all at or below the olecranon sulcus, which makes internal fixation exceptionally complex per se. What the CT scan can do is you can take these fragments, manipulate them around, and particularly try to understand the trochlea, because the trochlea is really not only in the center of the columns, but it's the articulating surface between the olecranon sulcus. 50% or more of the stability of the elbow comes from the contact pressure of the trochlea to the olecranon sulcus. So if we can get that back stably, it's really much of the battle. And so I can move this around to figure this out. One more thing. Timing. If you're going to go to the OR, it's a good idea, and a closed fracture, not necessarily to do it in the middle of the night, as I'm sure you're aware. And ideally to have some people in the OR who are familiar with the instruments, because as was already mentioned, it may not be the fracture amenable to anatomically shaped plates, and the need for some alternative implants are nice to have around. consider the patient always when making decisions, not only about what you're going to do, but what type of approach you're going to take. We're seeing much more in the way of comorbidities, as I'm sure you're aware. And a patient like this, with a good history, turns out to be relatively sedentary. And maybe there's alternatives to operative treatment. And we're going back to experience that has been well documented. This was a paper in the early 70s out of England where they just treated with a sling or a splint. So, and people euphemistically called it bag of bones treatment. But if you look at the group of older age patients, look at the range of motion. That's a functional range of motion. And more importantly, painless functional motion. The outcome of pain is really a critical outcome that we don't always talk about sufficiently. We stress motion, but pain is a functional devastating problem for some patients. And this is not normal, but if a patient can get their hand to the face and reasonable personal hygiene, it's probably a good idea. Bearing in mind that patients are living longer, living healthier, and lots of opportunities for activity. And if you look at both of these figures here, they're all putting weight on their forearms. It used to be thought that there was only a limited amount of weight allowed for total elbow arthroplasty patients, but it turns out not to be true at all. Anytime a patient just gets themselves off of a chair, they're putting much more stress than you think. The patient position you saw, and let me just say one thing about it. We have to keep in mind the hand. In an injured limb, especially an older patient with dependency, that hand can swell, and the swelling may, in fact, be a long-term problem in regaining mobility. So I like to always use sterile Coban and wrap it up sufficiently intraoperatively. Lots of different tourniquets. Some you can get up very high. Some people don't even like to use a tourniquet. It's dealer's choice, but having a way that you can get enough proximal exposure is good. And don't forget to sign your sites as well. Let's look at some of the exposures, particularly the olecranon osteotomy. And it's a concern always about creating a fracture, concern about wire migration. That was always a concern in the early literature. And for implants, screw loosening or implant exposure. One way to do this is to do your osteotomy in the center of the sulcus, where there's actually the least amount of hyaline cartilage. So by just elevating a little bit of the anconeus, not detaching it, just elevating a little bit, you can actually look in and determine where the olecranon center of the sulcus is, and then consider creating your osteotomy that way. A chevron shape offers a little bit more inner face of cancellous bone than a transverse, and it gives it a little bit of inherent stability when you are fixing it. A thin-bladed osteotome will complete the oscillating saw, and it allows you to have a little irregularity of the articular surface that adds to the inherent stability by elevating it up that way. We'll talk about the ulnar nerve next, but if you're putting your K-wires, keep in mind that where the radius is related to the ulna, because you can't really tell from a lateral x-ray, because the shape is dome-shaped of the ulna, where the tip of the K-wire is. And you don't really want it to go through the dorsal cortex of the ulna aiming toward the radius because that can become an impingement. So 2 parallel K wires. And then I particularly found that wires can be bulky and then can be problematic with the patient leaning on them. So by making 2 drill holes, spreading the olecranon wires over a wider distance allows you to use lower profile wires. So passing them through, then through Sharpie's fibers where the attachment of the triceps is to the olecranon, and then creating your tension tightening equally on both sides, and then doing it for both wires. And then to prevent the K wires from backing out is when you had drilled them, pull them back a little bit, and then cut them and bend them 90 degrees and then 90 again. So they'll really lock into the olecranon bone pretty well. And so there's your fixation points, and they're buried, they're in the bone, they don't back out, and bend the wires and bend them down so they won't, the threads won't bother the patient either. And here we are, just protruding the dorsal cortex, but it purposely aimed toward the ulna rather than the radius. And there are, of course, plates. People are enamored to them. If your wound breaks down, having plate is a little bit more problematic. And then a straight triceps split is nice, or a triceps elevation if you're considering total elbow arthroplasty offers nice exposures. The statement is true that post-op neuritis is more common than the literature says. And if you look at elevation of the exposure of the ulnar nerve, whether or not you transpose it or not, you need to know where it is. And one area that when you're going and looking at malunions, non-unions, or just problems late down the line of ulnar nerves, it's often compressed as it enters the 2 heads of the flexocarpi ulnaris. So whatever the approach you consider, release those 2 heads of the flexocarpi ulnaris. And my own preference is to mobilize them, the nerve, considerably proximally and considerably distally, but let it lie in that same area. Realize there was a tip that wasn't talked about very much in the early study looking at total elbows versus ORAF, and all had ulnar nerve transposition with a post-op neuropathy 20%. But following those patients, the neuropathy didn't last. And the same group in Canada did a more recent study prospectively looking at in situ placement, having lifted it up and then letting it fall down back, which is what I always like to do, versus endotransposition. There was really no difference in outcome. So if you see a patient coming in with ulnar nerve symptoms, substantial, maybe that's a good idea to make sure that it's in the soft tissues. One way or another, it shouldn't be near or touching hardware. We heard about the ideas of the medial lateral stability, and it's true. It's a very nice technique because it brings back the columns to and holding that trochlea together. This is the central focus of your goal, is to do that. Fractures don't always come like that, though. And sometimes, as Kim mentioned, if you look at the lower fracture patterns, you might want to build one main fragment distally onto the proximal humerus and then use that to build the rest of your articular surface, in contrast to the fracture that's above, where you may have to bring back the whole trochlea to the columns. So there's probably no major advantage biomechanically when you look at that in the lab. So either way, dual plates, perpendicular or parallel, are probably reasonably stable. And here's that patient that we looked at before with rather taking plates and just contouring themselves. Remember that some fractures are not amenable to anatomically shaped plates because they've lost their anatomy. And so being able to contact these plates may be very effective. And in this case, this patient had a very stable, not a very complex fracture, and a nice functional outcome. There are times, as I mentioned, that it may not be possible to do these anatomically shaped plates. Here's a woman who, in her teens, late teens, had a distal humerus fracture, and now she's 50 and has another one, which is a very low at the olecranon sulcus or below. You can see this in a better projection here. And actually, she created her own osteotomy by elevating a proximal tip of the triceps attachment. And here's the CT scan. And as you heard, a straight incision. I don't believe there's any advantage for soft tissue healing by going in a curve, because really the blood supply comes equally from either side. So a straight incision is just the same as, and sign your site, always remember that. And now we're exposing it, and because she had made her own osteotomy, we're going through a tricep split, elevating that small piece, and it's almost an olecranon osteotomy now. And now we're exposing the fragments, and if you start to believe that you can do this very easily, you'll need a little more time, because it's a very tedious thing to get one to the other, but take your time. And then in this case, we're building back the articular surface first, and then using these reconstruction type plates, contouring it. And if you can take the plate and bend it like this and wrap around the medial epicondyle, as illustrated here, what you have is the very distal screw going perpendicular to the medial epicondyle, going straight proximally, and then the next distal screw going perpendicular from back to front. So you almost have an interlock stabilizing that, and then a second plate applied because to get a better support, and then a third plate on the side, and you'll need some bone graft there. But again, in this case, we're not depending upon anatomically shaped plates per se. And here she is, and she's had not full extension, but full flexion. And finally, with these shearing fractures, there's not one type, and that's very important, because you may find a complete single piece, as illustrated here in the CT, or that may be split, like in this with the capitellum and trochlea, two pieces. And this is the thing to take home, that some of these will have a lateral epicondyle fracture as well. And when they have a lateral epicondyle fracture, as you see this CT scan in a sagittal projection, that lateral epicondyle is fractured and it's anterior. And what's happened is there's been an impaction of the posterior wall of the distal humerus. And when we try to reduce that condylar shearing fracture, we have to disimpact that posterior wall. Once you get to these more complex things, only part of it is a shear fracture, as I mentioned. The group in London, Ontario also had an identification of the same thing, and their point is the comminuted ones with or without posterior comminution don't do very well. Operative treatment makes sense, you can, but it's not so easy, and failed fixation has been reported. Arthroplasty has an advantage in an older patient, early function and motion, but it limits the function. And non-operative treatment may be okay for capitellum fractures, but If you let this shear fracture heal too proximally, it will be a block to motion. So let's straight dorsal incision or medial and lateral incisions may be useful. But if you can't get a good exposure, don't hesitate to do a lateral epicondyle osteotomy, because that will really help your exposure if necessary. And here's this case. And watch, when we take out the proximal radius and ulna, this thing really jumps. You can really see that lateral epicondyle and that impaction of the lateral column. And now he's fixed effectively. He doesn't have full flexion, but good extension. And notice how far through this lateral approach you can get to fixate the trochlea component. And sometimes I've used a small plate on the lateral side to help with that. These are some of the problems. There's been a recent meta-analysis and that have supported these, especially with the comminuted fractures. This was the first paper we published and had a pretty good motion, but some of these patients needed contracture releases. And two of them had avascular changes, but they didn't go on to necrosis. They revascularized, per se. And this was the results. They're reasonably good. The same with the group in London, Ontario. The 13 that were trochlea and capitellum in separate pieces had much more complications. So keep this in mind when you're looking at these. And then finally, we'll hear about therapy in the latter part of this program. But total elbow arthroplasty may be useful. I don't believe it's the preferred treatment if you can repair the fracture. But if you can't, it has a very reasonably goal to get early motion and stability. And it seems to be, as the implants are improving, to have a longer longevity. This is a paper from Mayo a number of years ago, and many of them were rheumatoid with an adequate follow-up. This is a good indication. If there's a patient with rheumatoid arthritis, it's an even better indication. And a patient who really has severe advanced osteoporosis. I think these are the good indications, and not so good if they've had wound problems or they're young and active. Hemiarthroplasty is just scratching its way on the surface here. It's not federally FDA approved, but in Canada it is, and in Australia, and the results are somewhat promising, per se. The difficulty is if you do a number of these, follow-up is very disturbing, because patients who are doing exceptionally well, some will come back. And probably the reason is, especially if you take off the condyles on both sides, is the joint, the arthroplasty is not put in the true axis. There may be a little rotational off, and it works well, but there's an underlying torque that happens, and that's why patients may show up with loosening down 4 or 5 years. So with that, I'll stop and hope that I've given you some pointers as well.
Thank you very much, Dr. Juper. That was wonderful. While Brent's getting his stuff loaded up, I was just going to ask, sometimes when you are looking at the articular surface, there can be really small chondral fragments, like almost just pure cartilage sometimes, like the cartilage is sheared off. What do you do with those? I mean, what's your advice on those really small pieces that you're not going to be able to get a screw in? How do we deal with those?
It depends where it is. The idea is you'd like to keep the width of the trochlea, the medial and lateral ridges of the trochlea to be the normal width, because that is the inherent stability. So if the deficit is sufficient that you might say, well, let me narrow the trochlea. Don't do that. Put in cancellous bone for those small flex, or even a iliac crest small core of bone to make up the defect. But
I see. Yeah. They can be, I mean, it's worrisome because you're thinking, should I save those pieces but they're just loose and what do I do? So I guess the point is don't narrow the trochlea, whatever you do. Yeah. Yeah. All right, Brent.
Are we good? Can you see
You're
me?
good. You're on.
All right. So it's an actual privilege to follow the mentor of Distal Humeruses, being just Dr. Jupiter. I'm going to try to show mistakes that I've made and mistakes that I've seen across, and hopefully we will, help each other. So you've got.
Sorry to interrupt. Do you mind swapping displays? You're in presenter view.
I knew it was going to happen.
I know it's
horrible.
just right up on the left side at the top.
Share. Do I go here?
Nope, up at the, let's see. Yep, perfect. Thank you so much.
I knew I would screw it up. All right, Dr. Jupiter's better than I. So we're going to just move forward and look at someone who, how do you avoid complications? I mean, it sounds great. Kim said all these things. We figure out the principles. Dr. Jupiter has shown his 40-year experience, and thank God we have that, but we're going to move forward. So complications do occur. All the ones I've talked about. No matter what you do, the ulnar nerve's in the wrong place, so it's a problem. Elbow stiffness is there. They're going to get osteoarthritis. Whether it hurts or not, who knows? And then infections are going to happen. You got hardware and you got implant prominences. So what do you do? Do you figure out a way to, or do you have to go back, or do you not have to go back? We want to try to decrease these problems. So go back to some of the things that have been talked about. You got to know what you're looking at. And some of the things can be simple, and some of the things can be difficult or more expensive. So if you look at just simple traction views, you take that x-ray up to the right, and then all you need to do is pull on it and figure out a better way of doing it. So CT scan does help. CT scans scare me, but it is nice to know, to know if you have those coronal shear fractures. But just doing something simple, this is done in the OR. You can figure things out as you figure out how you're going to fix these injuries. We know what the problems are, but there's ways of doing non-op. Patients can do, quote, bag of bones, as Dr. Jupiter talked about, and have patients that aren't the right person to make an incision on, no matter what you do. Conical arms in the middle of the Midwest are difficult to try to fix, and they may do okay with just non-operative treatment. So how do you minimize all these complications? We've talked about the different type of positioning. You got to make sure in the middle of a case with that typical conical arm that you can see to the right is that you can see x-rays, you can avoid problems, you can avoid nerve injuries, and just make sure that you don't have to do some, gymnastics in the middle of the case. So you have to be able to do every one of these. I don't like prone. It scares me for patients to be in that position because these cases can take a long period of time. But the more that you know how you can do things, and positioning seems like it's simple, it's sometimes turfed off to the mid-level or turfed off to the resident or others. I think it's a very important part for the surgeon to decide on. I like taking a Mayo, as you can see, up to the right and putting on the other side so that I can use that, one, for instruments, and two, to position the hand. How do you approach it? I learned from the mentor that just talked. You go straight down. What's that? Yeah. So you go straight down the middle, because if you do curvilinear incisions around the back, you will make these flaps die. So go right down the center. The blood supply comes from either side. How you get in there, there's lots of different ways. And what you do know, all those different approaches. Olecranon osteotomies I think are the best ways to do it. They heal. You're not creating another fracture. How you fix it? We know that chevron works well because it's more cancellous bone. We need to repair them however you want to do it. There's lots of different ways. That keep it simple, stupid is the best way to do it. In my hands, and whether it's tension band or a real small plate, it works out fine. But you will have complications with this. So the more you look at it, and the more you keep it simple and get your approaches, the better off you're going to be. So what's the tip to success? You can use a K-wire. This is brought up by Dr. Steinley, one of my partners. At this time when he was a resident, he made sure he put a K-wire right where that's supposed to go. There are guides that are out there now, but he knew exactly where to put it. You don't want to put it proximal, because if you put it proximal, you can't see enough. You don't want to put it distal, because if things fail, it becomes unstable. You want to make it just right. You want to put it right in the middle, and that's where it is. Because if something would happen, whether it's your fixation, whether it's your soft tissue, whether it's whatever it is, you can do an advancement and the elbow is stable. We know that the collateral ligament runs from the medial side down to the ulna, and you could take this whole olecranon if you had to. Do you want to? But you don't want to be in a point where this thing is too distal. So wound complications, they happen. We have papers that say it's more with plates. I'm not saying plates are wrong, but they can happen. I mean, you can, make sure you do all tension band wiring. I don't think that's the way it is. If you end up with wound problems, Dr. Bernie Murray talked about treating tibia fractures. If you have an open fracture and there's a plate there, let it heal. Right? Make sure you heal it around that area. So you can let this thing wait for a period of time, make sure it seals around it. And when it seals around, take the plate out afterwards. Or if you want to get aggressive or pseudo-aggressive, you can do a different type of flaps, whether it's radial forearm, whether it's FCU. You can cover those areas. Brachioradialis will do it. So there are ways to cover this. But the bottom line is protect that soft tissue. The neuropathies have been discussed. Great paper that's been written concerning the meta-analysis of this. I mean, I think where it is right now is if you do an osteotomy and if you keep that nerve in the right place, everything's fine. If you do transposition, as Dr. Jupiter talked about, you are moving the nerve. You are causing this. I think that is a very interesting point that he made, is that if somebody comes in with that type of, or comes in with a neuropathy, that maybe you should move it forward. So these are complications. And you can make really pretty x-rays and everybody can be happy and patting themselves on the back. But the patient has ulnar nerve symptoms, they're not happy with you because that's going to continue and continue. And so just watch yourself. Remember, you protect this area. So building constructs, anatomic plates are great. I was lucky and unlucky to grow up when there were not anatomic plates. So we know how to bend plates where they were. We know how to lock things in when we didn't have locking plates, taking, screws and interdigitating them, and to be able to get the same fixation. So they're good, but they're not perfect. So look at some of that stuff. 90-90 plating, whether it's Dr. Jupiter or whether it's Bob Hotchkiss, they all looked at this stuff in the past. Direct medial, throwing an extra plate lateral. You don't have to do exactly what the reps tell you to do. You can do a lot of different things, bending plates and protecting all these different areas. It's going back to principles. So fractures like this looks great. I use these anatomic plates and then, oops, it didn't work. Why didn't it work? We're missing concepts. And the concepts are probably the most important part of this. Sean O'Driscoll then moved forward. Dr. O'Driscoll moved forward after people like Dr. Hotchkiss and Dr. Jupiter to say, hey, here's another way of doing things. These original plates were not locking plates, so they had to interdigitate and figure things out. You want to make sure you would maximize, so it's a little easier to do this, and you wouldn't have to worry about those plates in the back. So they're technical points that we've heard about. So essentially every screw should get the fragment. common sense. That's just common sense you should work on. You shouldn't just use the plates as locking things. Engage the fragments. Make sure you get to the other side. Use as many screws as possible, meaning see if you can get some ways of fixing these things down there. Each screw should go anywhere it is. They should engage the articular fragments. You shouldn't just stop halfway in between. I mean, the screws should be in the distal fragments and locked together. So, if you look at these 8 things, if originally these plates did not have locking mechanisms, so it's trying to do in the old blade plate philosophy. If we had that, that would be nice. So just ability to kind of to use compression, because that's what we would do. Use basic principles, and make sure they're strong enough to move forward. So build a construct, and you can rebuild things. So how do you fix things? Start with comminution, try to put things together, build the spool back and hook it back to the humerus. That's kind of the easiest part. Build the articular surface, as you saw the great cases by Dr. Jupiter and that Kim talked about, is trying to get those things. Don't crush the articular surface. Put it back together. All right, so you have somebody with a ground level fall. You have these injuries that are there. You can get CAT scans. You can do all the different things you can look at. So when do you flip it up and join? When do you try to figure out other ways of doing it? Well, you can have ground level falls. These are all these distal fragments. These are the ones that, fortunately or unfortunately, that I've seen over the years, is these low distal humeruses. Oh my goodness, what are we going to do? You're gonna have problems with plates and screws. They're gonna get non-unions. They're gonna have issues as you move down the thing. These low humerus fractures have complications. They all do. And as has been stated before by numerous people, is that we have people that are living longer and longer and longer. So the 65-year-old, as you're hearing from a 65.8-year-old right now, these things are for older people, not for younger 65-year-olds, right? So how do you fix it? Brilliant thought process by George Dyer. Learned from him a couple years ago. Figure out ways that you can fix these distal fragments. These are great little tricks to figure it out. George did a great idea of figuring out how to fix these things distal. You put your K-wires across it, and we've all been there. You put the K-wires across it, you pull them out, and then you put a screw in, and everything goes to whatever. It all blows apart. So just use them as your fixation. You don't need compression. We know from Andy Palmer and others that compression's gone by the time you leave the OR. You're just trying to get stability. So it's just another way to think about it. Now we got last resort that was talked about by Dr. Jupiter. You can do a lot of different type of total elbow arthroplasties. The articles look good, but unfortunately, or fortunately, people live longer. So what happens when you have total elbows in a very active person for a period of time? I don't know. This one just showed up in my office yesterday. 61-year-old, 14 years ago, she had a very, very bad distal humerus fracture, and they decided to put a total elbow. Now she has polywear, as you can see on the lateral view. Now she has third-party problems where she's got loosening that's going to occur, and now we got to deal with it. And she's only 61. So it's not something that somebody should do right away. I think it should be in your armamentarium, that if you have to, it's fine. But realize that it's not a cure-all forever. Hemiarthroplasty, we've had an experience in Dayton. Overall makes sense. Just throw it out there. It's not FDA approved. I tell patients that when we start out, they seem to do well. If you've got a very comminuted fracture distally, you have to rebuild your lateral and medial side to try to put these in. You're putting essentially a non-anatomic distal humerus replacement. And what could happen? You come back and you'd flip to the other side. Seems like a little hemiarthroplasty for the hip. Not sure we have the technology completely. And I think we will in the future. It is something to look at. So these are complications that could happen. But when you have these very distal fragments that you can't fix with every trick you have, it's something to look at. So how do you prevent stiffness? As far as I'm concerned, it's movement. We routinely do not do prophylaxis. I don't think radiation makes a lot of sense. My anecdotal sort of snarky thing to say is, if you would do Indocin as in the literature, you would do it before the person fell. But that doesn't happen. There is steroid protocols that are out there. I don't have that experience. It does make a little bit of sense, but I think movement is the most important part of this whole process as we move forward. And hopefully you have good therapists, and you will get the patients to the therapist earlier than later. As you saw in my degree, I have a master's degree in PT, so I respect everything that they do. And the more we respect the therapist and work with them as a team member, the better off we are. We can't be sending them 3 months down the road and ask them to try to get the motion that we should have given to them 2 or 3 days after. So before you leave the OR, make sure you got full motion. Make sure you got flexion. Make sure your supination, pronation, you don't have screws that are sticking out somewhere. Don't have any radiocapitellar impingement. That radiocapitellar impingement can definitely be a problem. Instability, it's only if you create it. Most distal humeruses are not unstable. So you may have created in your approach. Watch your crepitus as far as the pins are, and watch your ulnar nerves if you take pins in there. So postoperatively, I usually split them in anterior, posterior splints at 45 degrees. It decreases some of the volume in the capsule. They'll get their motion back, especially if you're working with good therapists. I think that placing this position decreases some of your problems with wound complications. So it seems to work forward. So I appreciate the opportunity and honored to be on this panel.
Thank you, Dr. Bamberger. That was fantastic. That was great. Now, while Danielle's getting her talk teed up, I'd like to ask you, back in the day when you and I were training, we talked about if the patient had this fracture, presented with a fracture, and was perhaps 65 years of age, you just needed to do a total elbow. Like it was kind of that thing, that perception that there was a number attached to an indication of when you should do it. Now, to your point about, people are living longer, they're actually very active. What would you recommend now about, like, how do you make that decision about when is a total elbow replacement and actually an option? Is it attached to a number any longer? Is it attached to a fracture pattern? I mean, how do we decide that?
I think the biggest thing is you try to fix everything with every trick that you have. As I said, what George has done with the skinny wire fixation is some way to do it. And then if it doesn't completely work, we realize that the quote bag of bones technique has helped people. So if it's not really working perfectly, you're okay. Hopefully in the future, we have a better total elbow arthroplasty. But as I said, as a 65.8-year-old person, I don't want a total elbow.
Yeah.
I don't think it should happen. Hemi, it's not there yet. We had the advantage of maybe getting a certain company's anatomic hemi from France that got taken away. So everything we put in now is non-anatomic. I let them weight bear right away. When I have done hemis, we're up to maybe 15, 16 of those patients. But even those have problems. They can wear into the humerus, but I don't think we burn any bridges. So I don't think it's an age. I think it's more try to fix every single thing you can. But there are people that you can't fix. And if I don't have an age for you, Kim. I really don't know what it is. I try to fix everything and have the total, have the rep in the room to possibly do it. So.
Yeah, no, I think that's true. I mean, I think that's the thing is I think the number doesn't matter anymore. I mean, it used to be that was our guideline. I don't know, Dr. Jupiter, if you have a comment on that, but yeah, I mean, 65 looks younger and younger, I must say.
Jesse, I think you're muted.
I think you're on mute. Yeah, Dr. Jupiter.
It's really both a combination of patient profile and the fracture pattern. So as Brent said, many of these you can put together, but not all. But if total elbow doesn't always have in your back covered, so to speak, so you need to have planning for that as well.
Yeah, for sure. All right, so Danielle from the Indiana Hand Center, we're excited to hear about your recommendations for once we do all this construct and this plating, how can we make the patient happy?
Absolutely. If I might interrupt really quick before you start, do you mind swapping displays you're in presenter mode? Just right there at the top on the left.
I made no mistake too.
Yeah. There we go. So we're good. You guys can hear me and see fully. So, yeah, very much. I mean, the distal humerus fracture, the stiff elbows, they are certainly a challenge. And from the therapy side of things, we definitely have some input, I would say, we can share, and want to kind of give you some takeaways related to motion and kind of big picture approach and thinking when you're presented with a patient that's had a distal humerus fracture, recognizing the postoperative planning and how to coordinate with surgeon and get a good plan, and then some of the challenges and how to deal with some of those challenges. First, I want to talk about the therapy goals. The range of motion, of course, is very important, and we all want perfection. But there's a reality with a lot of these fractures and the complication. We really want to make sure we are staying focused on function, and what is the stick, what are the priorities, and what does the patient need to do with their upper extremity to achieve that true functional, return to life, return to normal activities. In that, prioritization of certain motions is going to be very important. It's easy to get hung up on some loss of elbow extension, but in the process, maybe really keeping in mind that the elbow flexion is so much bigger. It really, the pathway to touching your face and eating and everything, having that ability really trumps some of the other movements, and we have to kind of keep that balance as we go through and address these different motions with our patients. I do have a case study that'll kind of walk us through a couple of the key points and takeaways. This is a 55-year-old patient. She fell off her bicycle. She was allowed for early motion with good fixation. The 5 to 7 days post-op. This allows soft tissues to calm down. If we start 1, 2, 3 days post, very painful, extremely swollen. It probably still will be at 5 to 7 days, but allows things to calm down a bit. We do want to get them moving early enough that we can prevent the stiffness. As all the inflammatory response continues and scar tissue starts to develop, we really want to get ahead of that. The 5 to 7 days seems like a kind of key time point to get started. That flow doesn't happen in a clinic, but that can be something that is kind of in the planning process on the surgery side. That therapy initial visit is going to start around that time frame. That is hugely helpful and really beneficial for the overall outcome. In that, edema control is a big. The bulky dressing, of course, helps with that. But once we take that off so they can get moving, we can transition to things like elastic stockinette that give them a lot more freedom of motion. An ace bandage and all the gauze really gets kind of bulky in that crease of the elbow as they try to move. And so one technique is using something like stockinette. We even sewed the little edge there, you can see, to taper it down to get the best compression we could for this patient. Motion, of course, is huge. And in the first 2 weeks, I would recommend beginning with a limited arc of motion. So not starting with, let's be aggressive. Patients are going to be painful. And they're going to be hesitant. They're going to be scared to move. We want to do slow, pain-guided motion, long holds at the end range, gentle long holds. And then a consistent routine. If patients really get into that routine of regular exercise, that is a huge barrier, and that can really set the stage for the coming weeks. You get more involved with the exercises. We want to make it achievable. We want the patient to feel like they are, succeeding in the therapy. That can help reduce fear, anxiety, frustration, and that kinesiophobia, at 1 week and self-efficacy in the first month are really predictors of how they're going to be doing at 6 to 9 months. So if they're able to cope, they're able to overcome, persevere with these initial phases of safety, they really can have overall enhanced recovery. After your kind of shorter arc, we'll get into full active motion. I always like to put the patient lying down, of course, to support their scapula and keep the humerus from, kind of compensating and cheating. And then we can also use gravity to our advantage when they're lying down in this way for extension. And then in that picture on the top right, kind of propping the arm up perpendicular to the ground and allowing that elbow to just flex with gravity. And that can be very, very helpful. You can also add a little bit of a can weighted stretch with that as well. Self-passive can be challenging for extension in particular. Patients, it's just hard to reach, especially if they have a larger build of their body. It's hard to reach across and actually get any good leverage. In the picture there in the bottom left, she's using the table to leverage against to get some self-passive. And then the passive range of motion is going to be helpful. I love good blood flow, helps, relax the patient, dampens the pain, and then nice slow stretch can help us achieve that a little easier. With forearm exercises, one way I found is very helpful in achieving supination and pronation is to flex the elbow while supinating and extend the elbow while pronating. This was an article on et al. That really talks about the PRUJ space and how that affects the radial head translation, gives us a little more space. And I found anecdotally time and time again that patients benefit from this. So I think it's super helpful and a good way to, really actually kind of a functional type of movement, like splashing water on your face, reaching for the keyboard is how I describe that. And patients seem to do really well with that kind of approach. Orthotics are going to be an important piece to the overall therapy as well. Initially, we're going to put them in a long arm orthosis for protection, for rest. That's going to be their daytime orthosis. And begin weaning that after a week, the surgeon allows. It's good fixation and starting some light activity. That's advantageous as well. And at nighttime, wearing a custom elbow extension orthosis to help recapture that extension. That same orthosis can be used as a serial static orthosis, where, the initial 10 days, kind of phase, we have a certain angle that we're kind of stuck at. Over time, we can increase that angle and adjust that orthosis to achieve a greater amount of extension. We also can move into static progressive orthoses, and there's a variety of options. I'm a fan of custom orthotics, especially when it comes to elbow flexion and extension. Some of the ones on the market just don't fit as well. And you'll notice here in our elbow flexion crease foam strap, a lot of the other devices out there, they have a stopping point at about 150.
I wonder if we're having a little connection issue with Danielle.
It seems that way.
But
Yeah,
the
is she
big
back?
picture is
Okay.
function is the priority, and we want to be sure that they are achieving good function in the end of this whole process. Early therapy, good communication with the surgeon, and a good, good open dialogue with your therapist is hugely helpful. And then starting with like a gentle motion program, so we can more easily kind of progress them through. I think those are the big picture takeaways as far as therapy. Simple, but simple is, sometimes the best approach. But yeah, thank you.
Thank you. Thank you very much. I appreciate that, Danielle. So a question for you. You talked a little bit about the dynamic splints. I mean, are you a fan of those? As in the Dynasplint world and those, there's many out there. What do you think about those? Do you kind of like to?
I like my custom orthotic better. Oh, sorry. We broke up a little bit.
Yeah.
I think I got your question. And what do I think about the braces that are out on the market and some of the options? And I'm personally a big fan of the custom orthotics. And when I made change to some of the alternatives options out there, I don't think we have a great custom option for Supro. And so if I'm trying to recapture Supro, we're not getting it through normal methods. That is a place I will order an outside device. A lot of the devices take a lot of time and approvals and authorization, so it's a challenge. But the custom elbow flexion, I'm not a fan of the options out there because I think our custom made is better.
Yeah.
And then the prefab extension, I think I could go either way. I think that's when it's more of a hard infield that sometimes you have to opt for the more like high temp thermoplastic versus our low temp thermoplastic.
Sure. And one last question for you. If in a perfect world, when would you like to see this patient? Like how many days, weeks post-op do you want this patient to show up?
I'm a little bit of a minimalist on therapy. I put a lot of onus on the patient to do their home program. I would probably want to see this patient at 5 to 7 days post, and then I want to see him twice a week. Once we're seeing good progress, I'd probably back that off.
Yeah, that sounds great. And with this new fixation or improved fixation, hopefully we should be able to do that, right?
Yeah.
So that's great. So great. Well, thank you. Thank you so much for your perspective. I appreciate that. So I have a question for my other panelists, Dr. Bamberger and Dr. Jupiter. Bone graft substitute, if we need it, yes or no? What do you guys think? Dr. Jupiter, maybe you first. What do you still go iliac crest if needed? Do you like bone graft substitute? It's very popular, obviously, these days. So what do you think?
No, I don't like them.
Why?
Well, I like osteoinductive and conductive. So I think that's why I will always expose the iliac crest just in case, prep and drape it, and also have permission from the patient. You don't need a lot, but as you asked the question about missing some fragments, I think your own bone is the best thing. Allograft or bone substitutes are just that. They're non-viable tissue.
Yeah. Brent, do you have a comment?
No, I completely agree. If you need good cortex, if you need something to substitute that area, you should do it. I'm not sure what all the little little fragments are for. They're not going to help anything. The bottom line on some of these is, you could always shorten humerus. You want to get that articular surface looking good and shorten things up to the humeral shaft. And so if you got to rebuild an articular surface, you go the iliac crest. If you are trying to put some little flex into the metaphyseal area, I'd tell you just to shorten it down, because that's probably a person that may not get full range of motion, but you got to get that articular surface hooked to the humerus. So I agree with Dr. Jupiter, which I have to. No, I don't have to, but I always do.
Well, that's great. Thank you, guys. Thanks, Dr. Jupiter, and to Dr. Bamberger, and to Danielle. Thank you so much. And does anybody have any other questions? Any other comments they would like to share? We're kind of at our 75 minutes, and I think we've had a great discussion. I've really enjoyed it. Anybody have any comments?
There was two things on the on the chat that were interesting. One is I think Kim, you talked about it, the olecranon osteotomy. I mean, I still think that's the best way to do it if you do it right. But you have to know how to do the Brian Morey approach. You have to know how to do this sort of para olecranon approach, lifting the anconius. I'm just not good enough at those. I need to see everything. That's one. So
Yeah.
I don't know.
Now the question was, how much do we value the olecranon osteotomy as an approach to an intra-articular fracture? And my answer was, it's a game changer for me. I mean, I wouldn't consider probably doing these really common intra-articular fractures without it, but it's not the only approach. I mean, to Brent's point, you have to have, if you're going to be treating distal radius or distal humeral fractures, you have to have comfort with more than one approach. I don't know, Dr. Jupiter, do you have a comment?
It depends upon the fracture. As we looked at, the fractures that have larger distal fragments, I think, can be done through a triceps split quite effectively, or even from side to side. But when you're talking about the low fractures at the level of the olecranon sulcus or distal, there's less trouble when you use an olecranon osteotomy, better exposure.
But I think your point's well taken. And talking about the shear fractures in the front, as far as some people still do those for an olecranon osteotomy. I don't like that. That thing you talked about doing a osteotomy of the epicondyle, that can flay it open. That's an old approach, as we all know, that was used for total elbows, just to get that shear fracture taken care of. So you have to know all the different approaches. Yeah.
And Emil's asking us a question. He's asking, what do we do with the anconius when we're doing this approach?
Well, I think if you can try to preserve as much as you can. The anconius originates much more proximally. So with the olecranon osteotomy is you can still leave a good part of it intact, and the blood supply to the proximal part for sure.
I agree.
Yep. Sounds great. Well, again, thanks to my panelists, Dr. Jupiter. We thank you very much for sharing your wisdom with us and spending your time with us tonight. And I've enjoyed it tremendously. Dr. Bamberger, thank you as well. Danielle, thank you for your insight, and I appreciate it. I think it was a great discussion. So I think on that note, we can say goodnight and wish everyone a good evening, and hope to see you again here soon on our next session.
Thank you.
Thank you very much.
Thank you.
Thank you. Good night.